Hello, my name is Thomas Wright. I'm a surgeon at the University of Florida in the Department of Orthopedics. The purpose of this videotape today is to educate you on shoulder replacement surgery. We're going to talk about all aspects of shoulder replacement surgery, including who needs it, generally people who have failed non-operative management and have significant pain and dysfunction. We'll discuss the procedure itself, the hospital course. Rehabilitation will be discussed by Mike Criccio, one of our therapists. The research initiative will be discussed by Amy Struck, our research coordinator. And finally, in conclusion, Dr. Jay King, one of my partners, will give us the conclusion. In a spirit of disclosure, I've been involved with the design of implants discussed in this video and benefit financially from their use outside of this institution, as do several members of my team. In addition, the institution receives research support from industry discussed in this video. The reverse shoulder replacement was approved by the FDA for use in the United States in 2004. It is a reverse ball and socket joint, the opposite of an anatomic shoulder. The indications for use are pain and dysfunction that have not, patients who have not responded to non-operative management. And these are patients that have rotator cuff defects that are too large to be repaired, severe socket wear, revision surgery, fractures, advanced age. The risks associated with this procedure are anesthetic and medical risks associated with any surgery, which may include pneumonia, heart attack, or pulmonary embolus, just to name a few. These are very uncommon and are generally correlated with the health of the patient. Surgical complications themselves are infection rate of 1 to 2%. In that case, sometimes the implant needs to be removed. Dislocation rate of 1.5%. Bleeding at the University of Florida rate of less than 5% need for transfusion. Nerve stretch occurring about 5% of the time, which can leave you with some burning pain and weakness down the arm, generally temporary but not always. The wear rate of the implant itself, which is mechanical, is approximately 10% revision rate at 10 years. The new implants that we're currently using is probably less than that, although time will tell. Other issues can occur as stress fractures. These are rare, of the acromion, and some lesser complications. The overall complication rate is less than 10% at the University of Florida, which is far less than has been reported in the literature. The operation performed itself in the hospital. It's done in a regional and general anesthesia. It is performed with a real incision on the front of your shoulder. The implant itself I'll show in a minute in a model. The operation takes approximately 2 hours. You stay in the hospital overnight, usually going home late the next morning. Your expectation should be that 90% of patients should have significant pain relief after the rehab course. Elevation, ability to raise their arm above 90 degrees occurs in 90% of patients. Return to recreational activities, including golf, in about 4 to 6 months. This is a model of a shoulder. This is like it's my left shoulder, the shoulder blade. In a total shoulder or an anatomic shoulder replacement, we replace the socket with a plastic socket, and on the humeral side or the arm side, we actually remove the old arthritic humeral head, place a stem down there and the ball down there, and this is what we call an anatomic shoulder that moves with the use of your rotator cuff and deltoid. If an anatomic shoulder is not being performed, then option is the reverse shoulder replacement, which we discussed earlier. In this case, the socket is actually placed on the humerus or the arm side, and the ball is placed on the socket side. So the anatomy is flipped, and the large deltoid muscle raises the arm in this case. My partner now, Dr. Kevin Farmer, will discuss the anatomic shoulder replacement.
Hello, my name is Kevin Farmer, and I am a sports medicine and shoulder specialist here at the University of Florida. I would like to take a few minutes to explain the anatomic total shoulder replacement. I will go over the surgery itself, the risks and benefits, and the post-operative course. For the purposes of full disclosure, I am a paid consultant and help with surgeon education for some of the companies that we may use, but I do not receive anything for the products that I use in my cases. The anatomic total shoulder replacement is a replacement of the ball and socket part of the shoulder joint. The arthritic ball part is removed and a metal stem with a metal ball is placed to match your anatomy as closely as possible. The socket is also removed and replaced with a plastic component. The goal of the surgery is first and foremost pain relief. This operation typically does a very good job with that. Range of motion outcomes are dependent on a number of factors, but often are also very good, with forward elevation typically over 135 degrees and external rotation over 30 degrees. Internal rotation can often be expected to be to the lower part of your back. There are risks for any operation, including infection, which is less than 1%, bleeding, injuries to nerves, blood vessels, or other vital structures, fracture or dislocation, medical risk including blood clot, heart attack, or stroke, and the risk of anesthesia, which do include death, although extremely rare. Although rare, infection is a big problem because the implant will often have to be removed and the infection will have to be treated with antibiotics prior to reimplantation. You will typically meet with the anesthesia team at Shands well before your scheduled surgery during your pre-op visit there. They will go over your medical history and you will often have preoperative labs drawn. On the day of surgery, the anesthesia team will talk to you about a nerve catheter. This is a device that numbs the nerve to your arm, helping with pain. The catheter is often left in place for up to 3 days and is then easily removed by your family. The anesthesia team will go over the risks and benefits and the instructions with this in more detail on the day of surgery. The surgery itself involves an incision on the front of your shoulder and requires full anesthesia. You are typically in the hospital overnight and go home the next day after seeing physical therapy. You will be in a sling for 6 weeks and will be in therapy during that time as described by one of our therapists in this video. It is imperative that you follow the therapy plan as prescribed to ensure the best possible outcome. You are typically in therapy for 3 to 4 months and usually return to unrestricted activities by 6 months. This is an overview of this process, and the goals may vary amongst different patients. Please feel free to ask us any other questions you may have as we move forward on this journey together.
Hi, my name is Mike Cruccio. I'm an occupational therapist working with Dr. Wright. Today we're talking about rehab following reverse and total shoulder arthroplasty. There are 4 points to consider when thinking about the rehab of reverse or total shoulder arthroplasty. You will have a pre-op visit, you will have a 2-week post-op visit, a 6-week post-op visit, and a 12-week post-op visit. We'll be talking briefly about each of those points. Preoperatively, you will receive measurements for range of motion, pain, and strength. They will serve as a baseline of comparison. Also at your pre-op visit, you will receive a soap. This soap we would like you to bathe with 3 days prior to surgery. You'll bathe from neck to toe. We ask that you not bathe your face, wash your face, or your ears with this soap. We ask that you not apply any perfumes, lotions, or deodorants after the use of that soap. And again, you'll use that for 3 days prior to surgery. During your introduction pre-op visit, we will be going over positioning as well. It's important following surgery that your shoulder never fall below your side for the first 6 weeks. So when doing exercises, we ask when you're lying down that you have a towel roll or a pillow underneath your side. We ask post-operatively that you also come with a blousey button-down shirt. This will be helpful. You'll be wearing a sling for the first 6 weeks following surgery. So your preoperative visit, again, we'll consider range of motion, pain, strength, and we'll go over positioning and use of your sling. At 2 weeks post-op, if you've had a total shoulder arthroplasty, at that point we will begin range of motion of the shoulder with a Codman exercise or a pendulum exercise and passive range of motion. It's important that your caregiver be present for all of your visits. Your caregiver will be the individual performing passive range of motion. Passive range of motion is someone else moving the shoulder for you. It's critical that that caregiver be around to perform these exercises at least twice a day for about 10 to 15 minutes per session. During this time, there's no active movement of your shoulder, no lifting, pulling, pushing, or any resistance of any kind for the first 6 weeks. During your third period, the 6-week period, at this point, you'll be able to actively move your shoulder or actively assistively move your shoulder. Actively moving your shoulder is when you move your shoulder by yourself. Active assistive movement is when someone else is helping you move your shoulder. At this 6-week point, it is a safe period to both actively and actively assistively move your shoulder. At this point, we still don't want you bearing any weight, lifting, pushing, or pulling with your shoulder. At this point, your caregiver will receive a break and they'll be no longer be doing passive range of motion with you on a regular basis. During the third period, or the 12-week point, you'll be able to begin conditioning or strengthening of your shoulder. At this point, you'll be able to bear weight through your shoulder, you'll be able to perform resistant exercises, and you'll no longer have any restrictions. So all precautions of lifting, pushing, and pulling will be lifted at the 12-week point. At this point, you'll be able to freely move your shoulder actively, be able to push, pull, and carry and lift things, and resume normal daily activities. Along the lines, if you have any questions, we invite you to call your therapist or contact your therapist. You will receive written information at the pre-op period, the 2-week period, the 6-week period, and the 12-week period outlining your course of rehab. Thank you.
Hi, my name is Amy Struck, and I'm a clinical research coordinator in the Department of Orthopedics. Our goal is to provide you the best possible outcome following your shoulder replacement surgery. During your preoperative appointment, you will be asked to fill out a questionnaire that will give your physician a better understanding of your pain and function going into surgery. After surgery, starting at 12 weeks, you will be asked to take that same questionnaire and continue to have range of motion and strength measurements to make sure that you are progressing through your therapy as expected and maintaining your function after your formal therapy is completed. During your appointment, you may also meet with a clinical research coordinator to discuss some of the current research projects that we have going on in the department involving shoulder replacement research. Over the years, we have made great strides in improving our patient outcomes, but none of this would have been possible without previous patients participating in research. You too will have the opportunity to help future patients by participating.
Hello, my name is Jay King. Thank you for watching this video about shoulder replacement surgery. Our goal is for you to have a safe and successful surgery that would help improve your pain and ultimately your lifestyle. As every surgery has its risks, we aim to minimize the risks and maximize patient benefit. Our physicians and staff strive every day to make sure our patients have a pleasant experience here at the University of Florida. Thank you.